So good afternoon, everyone. Thank you for joining us for today's psychoeducation webinar with Navi Greater Cleveland Understanding. Oh, no, I noticed in the chat, is anyone having a difficulty hearing me, or are we okay? Like,
yes, the sound is not good.
Okay, let me try something else. Let me.
How about now? Is that better?
Yes, that's better.
Okay, thank you. Thanks for letting me know that. So thank you everyone for joining us. My name is Matt. I am the Outreach and Education Coordinator for NAMI Greater Cleveland. Very happy to have Madeline Hodgman-Korth joining us today for our webinar on understanding mental health considerations for transgender and non-binary people. Just a few notes, please. Utilize the chat feature if you have questions. We will be monitoring the chat throughout the presentation. Please also note that this is being recorded and will be uploaded to the NAMI Greater Cleveland YouTube channel later this week. You will also receive a copy of these slides in a follow-up email afterwards. And please remember to remain muted during the presentation so that we can limit background noise. This webinar is scheduled for 90 minutes, so we may go till 1:30 p.m. Eastern Standard Time. We've got a lot of material to cover. Hopefully you'll be able to join us for the length of the duration of the webinar, but if not, again, you can find the recording on our YouTube channel later this week. With that being said, I think I will hand it over to Madeline to introduce herself and get us started. Thank you all for being here.
Hey, hi folks. It's nice to see so many faces and so many people joining us this afternoon. Like Matt said, my name is Madeline Hodgman-Korth. I'm a licensed independent social work supervisor. That's a mouthful. In the state of Ohio. I've been in the field for, I think this is my 7th or 8th year at this point, so a little bit of time now. And I'm really excited to talk to you guys this afternoon about one of my favorite topics, one of my niches as a therapist and a social worker, which is mental health among trans and non-binary clients. So we'll talk a little bit today about kind of considerations for other people in the mental health profession, so other clinicians or other members of the field. We'll talk about things for all of us Ohioans to be thinking about for this population. And we'll also be talking about how to support trans and non-binary loved ones, because I know that many of us have these people in our families or our support systems as well. So before we get started, I always like to say a little bit about me, kind of socially locate myself, if anybody wants to dive into the sociology of it all today. Just so you know my perspective and where I'm coming from before I start yammering on and on about data and research. So a little bit about me. You know, I'm a social worker. I identify as a bisexual person. I am cisgender. We'll get into more terminology a little bit later. I use she, her pronouns. You'll also see those in my name on Zoom. If you would like to also put your pronouns so that if you have a question or you raise your hand at some point, Matt or I know how to refer to you, that would be fabulous. If you're comfortable. A little bit about my background, I guess. Right now, I'm a therapist in private practice. I own my own practice in Cleveland Heights. Before this, I was at a group practice for a number of years. Before that, I worked in Cleveland Clinic, Akron General. And before that, I was all over the place doing all kinds of things, as many young social workers are. My specialties right now are sex therapy. I did the University of Michigan Sexual Health Certificate program and graduated this spring, which is pretty cool. I still have some supervision hours left, so don't call me a certified sex therapist just yet. Just know that I know the stuff and I'm working on it. My other niches would be LGBTQIA affirming care, so working a lot with members of this population for individual, couples, and family therapy. And I do see a good number of couples right now, so I would say that that is also a specialty of mine. If you have questions about I don't know, my background, career things, whatever, I'll give you my email at the end, but I'm going to try to stay away from that nonsense as much as I can today so we can stay on the topic at hand. So I would love to know, just because I'm curious and like a teeny bit nosy, if anybody is comfortable sharing a little bit about you in the chat too, because today is about you and me and the learning community that we're creating together. So if you're comfortable, I would love to see in the chat, and I'll look at them a little bit later, what got you interested in this topic today? What made you sign up for this webinar? What you're hoping to learn, if anything? And if you have some big questions, I would say drop them in the chat. I said raise your hand, but I think Matt and I were talking before about if a big question comes up for you while we're in the middle of a topic, that might be a better time to raise your hand or ask that question. Otherwise, I would love to have like a big pool of questions to come to at the end as well. So those are kind of what I'm asking of you as we start this learning community today. And one thing that I put on here, I also teach college classes every once in a while. So I always love to have like a little reflection question to kind of roll around in the back of your mind while we're working. One thing I'd love for all of us to be thinking about today is how our lived experience shapes our understanding of this topic. So for example, you noticed at the beginning that I told you a little bit about how I identify, a little bit about my background. All of those things and so much more shape my understanding of mental health among trans and non-binary people in different ways. Some ways that I'm sure you'll pick up on both explicitly and implicitly throughout this presentation. And so for you, I would also love for you to be kind of noodling on the same thing. All right, I see people working in the chat. I'm gonna move on to the next thing. So already we are what, like 9 minutes into this presentation, and I have used some terms and some acronyms that I'm guessing are new for folks. So I thought it best that maybe we start with some definitions. So these will be terms that you hear kind of throughout the presentation today. So first things first, today we're going to be talking about transgender people. So according to the National Center for Transgender Equality, which is a legal and advocacy organization working with this population, transgender can be thought of as an umbrella term. So it's a broad term that can be used to describe people whose gender identity is different from the gender they were thought to be when they were born. So when I say an umbrella term, I'm talking about a term that contains a lot of other information and definitions underneath it. So this means that some people might identify as a transgender man, a transgender woman, as transgender and also non-binary. They might identify as any number of these combinations of terms. Trans is the shortened version of this term. You'll hear me kind of use both interchangeably. I find that when I give presentations like this, I often sound so formal and so different than how I talk in real life, like when I am with clients or certainly with friends or family. So I will try to stay in my collegial terminology space today so that I'm not coming across too much like you're in a college class. So you also heard me use the term cisgender a little bit earlier, and that's how I talked about myself. I am a cisgender woman. Cisgender is not a derogatory term. Sometimes people might hear this and think, ooh, what does that mean? I've never heard that before. And when we're confronted with new information, it can make us a little bit uncomfortable. This is not meant to be an insult. It's not meant to be a hurtful label. Just like transgender is a neutral label for people who are not cisgender. Someone who is cisgender is just someone whose gender identity, the way that they identify, is congruent with their sex assigned at birth. So sex assigned at birth is really exactly what it sounds like too. This is a term that we've used in the medical and legal literature around gender identity since the 1960s. So as I'm sure you're guessing, longer than I've been alive. That's a long time. Sex assigned at birth is just that moment when a physician or a healthcare provider tells the new parents what gender their newborn is after they are born. That being said, their guesstimations on somebody's gender based on their sex assigned at birth is not always accurate. So to use myself as an example a little bit, one thing that you probably can't tell because of very strategic camera placement is that I am about 8 months pregnant right now. As far as I know from genetic testing, I am having a baby with 2 X chromosomes. So we think that she will probably be a girl. So that means that when she is born, when she's out, when she's all cleaned off and they hand her to me, they're probably going to say, it's a girl. And my partner and I are going to go, yay, it's a girl, she's healthy. That being said, sometimes months, years later, kids tell us, oops, I think you got it wrong. I was assigned female at birth, which is AFAB, another acronym you'll see in this presentation. But that's not how I think of my gender identity. I don't identify as a girl. So using terminology in this way, talking about someone's sex assigned at birth as kind of a separate, an ancillary, an additional piece of information to their gender identity is a respectful way of talking about their life experience. So I haven't even met this baby yet. I don't know anything about them. I'm hopeful that I can create a relationship with them that later on, if we've got it wrong, if we've made a mistake, we can talk about it. And part of that is making space for these conversations, which is what we will talk about as we go through this presentation today. So in the literature, as I was getting ready for this presentation, I found this kind of outdated term, biological sex, that seems to come up a lot in media, a lot in news about how there are a lot of people who feel very strongly that sex is biologically determined. In the mental health space, we try to talk about this a little bit differently. That yes, there is a biological component to talking about sex and gender, but that it is not quite as cut and dry as we were taught to believe in 9th grade biology. So yes, all of us have chromosomes. Some of us have 2 chromosomes, some of us have extra parts of our chromosomes. Like there's a lot of genetic diversity in the human race. Some of us have 2 X chromosomes, some of us have an X and a Y. If we were to look at the genotype of human experience, like all of these chromosomes lined up and categorized and analyzed, there's a lot of information there. And that being said, looking at somebody's genes and then looking at them as a person does not always give you a congruent picture, does not always give you what we would expect. So this term, biological sex, has really risen to prominence in media only in the last 20 years or so. We've noticed it more and more in conversation around trans rights, around taking away rights from transgender people. It's used in a legal capacity to try and lend scientific credibility to this idea that there are only 2 sexes, male and female. But what we know from the research, if we look at actual biology, there are many biological ways that sex and gender can present. So for example, we'll talk about this a little bit later, there are lots of people who have sex traits of what we would consider both male and female people, who identify either as male or female or as neither or both. These people are still real people. They can still sit across from you at the table and drink a cup of coffee, but they don't neatly fit into this category that we as humans, as a society, have created. So in doing this research, there's a lot of conversation in legal scholarship right now about how we don't have an agreed upon finite definition of biological sex. And so until and unless we have that finite definition, this term doesn't really help us to talk about the diversity of human experience. So in short, we're talking about the difference between your sex assigned at birth and your gender identity. So your gender identity would be your internal knowledge of your gender, of who you are. This would be your internal knowledge that you are a man, a woman, a non-binary person, another gender. We'll talk about some of those different ways that people identify their gender. So for me, I am a cisgender woman. I identify as a woman. I use she, her pronouns. These are all pieces and parts of how I describe and express my gender. Gender expression is how a person presents on the outside. So what you see when somebody is sitting across from you having that cup of coffee. This can be feminine, can be masculine, can be someone who is more androgynous, meaning traits of both femininity and masculinity, or it can be something different, something that we can't quite categorize as easily. So I am a fairly feminine cisgender woman. That is something that I choose to express. That's how I feel most like myself. That might be different for different people. There was a phase in college where I had a buzz cut. I really liked playing with gender roles. I might do that again someday. Who knows? Life is short. But gender expression does not always equal gender identity. During that time that I had a buzz cut, I still very strongly identified as a cisgender woman, just one with a really cool haircut. So again, this is what I mean by an umbrella term. So you can kind of see my cursor, or at least I can see my cursor. So for a lot of people, transgender is a big umbrella under which there are other terms and definitions, other ways that people can identify their gender identity. So some people who are transgender identify as a binary trans person, as a transgender man or a transgender woman. This kind of correlates with what we talked about a little bit earlier, the gender binary, the idea that male and female are the two primary categories of gender. Under the trans umbrella, there can also be room to discuss non-binary identity, meaning people who don't identify as a man or a woman, or only as a man or a woman, but might identify as both, as neither, as all of the above, as something completely different. And within the non-binary category as well, there is a lot of diversity in how people describe themselves, how people present, how people express their gender. So I kind of love this graphic from the University of Windsor, which is in Canada, about how non-binary people might use any different pronouns. I have plenty of clients who use any and all pronouns. And so when I talk, I might be switching between she, he, they, all of the above. They might use any label. They might present very differently their gender expression on one appointment to the next. They might sometimes feel more like this term accurately describes how I feel about my gender, and other times feel that something else is more accurate. So you can see that there's a lot contained under this umbrella. There's a lot of complexity. Again, the human experience is so much more diverse and rich than we can possibly capture in a graphic. I'm going to take 1 sec to look at the chat because it looks like there's a lot going on. Okay, is everyone answering all the fantastic questions from the beginning? Okay, I'll come back to those later. So a lot of non-binary people might also resonate with the term gender nonconforming. And what this means is that I think we can all relate to the experience that of having expectations for how our gender should, quote unquote, perform or should behave as a member of that category. For example, I know that in conversations with my dad, for example, that we've talked a lot about the expectations for older men in our society, that he's looked to as an authority figure, and that he's a pretty affable guy. And he often feels like, I don't know what's going on. I want to defer to other people. I want to hear other people's experiences. Why is it the default that I am the one in charge when people are looking for advice, either at work or socially? So, gender nonconforming refers to experiences of people that don't fit the expectations we have for that gender. So, my dad, pretty affable guy, pretty comfortable with his gender. He's a cisgender man. And so he really likes to wear a wig on Halloween. He thinks it's fun. He thinks it's silly. It doesn't threaten his gender identity. It doesn't invalidate how he feels about himself. He thinks that it is part of his costume and it is something that he feels totally comfortable with. Other people might look at that and say, that person is not acting the way that I would expect them to based on what I think about their gender expression. This is something that doesn't quite make sense to me. Now imagine that it's not just Halloween, that this is somebody's experience all of the time. For people who identify or resonate with the term gender nonconforming, they may not identify with the gender binary at all, 365 days a year. They might use different terms to describe their gender identity. They might always feel a little bit like playing with gender or exploring gender or pushing those boundaries for themselves is when they feel most like themselves. I can imagine that for those people, they both feel like this is how I feel most me, and this is something that I get a lot of response, a lot of pushback on from other people. So some people who are gender nonconforming might use the term non-binary to talk about themselves. They might use they, them pronouns, which you can think of as gender neutral pronouns. They might not do either of these things. They may use other terms as well. So it's important to keep in mind as we talk about this too, that non-binary people have always existed. That I know that in recent years, there have been a lot of really interesting pieces of research that have come out about how there is an increased incidence of younger people, so Gen Z, millennials, maybe even some Gen Xers, identifying as non-binary or gender nonconforming. But that doesn't mean that people didn't identify this way in prior generations or in years past. For example, you'll see on the screen in front of you that in other cultures even in North America, there have always been people who identify outside of the gender binary, and that those people actually also often hold really important roles in their culture. That the idea that someone who does not conform to our societal or cultural gender expectations is not acceptable or is a trend or whatever else you might hear about this group of people is a pretty new idea, a pretty Western idea too. So these are just 3 examples that might be interesting to look more into. But also, there have always been non-binary people right here in the United States as well. There are lots of people who are elders in the LGBT community, so in their 70s, 80s, even above, who identify as non-binary, who use different terminology too. That's something that changes with the generations as well. And they've always been here. So when we see this research coming out about more and more young people identifying as non-binary or identifying as transgender, I think what we're really looking at is the effect of more acceptance or more accessibility of this information. If more people are able to have an understanding and an acceptance of who they are, then I think it's kind of a cool thing that they're able to more accurately describe themselves too. So some other terms that you've seen on slides before that you might see today are other terms under the trans or non-binary umbrellas. One of these terms might be genderqueer. I know a lot of folks who identify as genderqueer, both on my caseload and in my life. This is a term that refers to people whose gender is outside of the gender binary. This might be talking about how they embody both masculine and feminine traits, that they embody a secret third thing, as my clients like to talk about, or that they feel like their gender isn't something that they can accurately describe, that using the term queer, even though that might have been used in a derogatory way in the past, is a way of kind of reclaiming that term, of saying, this is something about me that does not fit the norm, that I want to celebrate, that I want to lift up. Another term that you might see is agender. This typically refers to people who do not identify with gender, period. They don't resonate with masculine or feminine traits. They don't resonate with gender as a whole. You might also see bigender used to describe people. Typically, I've heard people talk about bigender as two or more genders fitting how they describe themselves. You might also see gender fluid used as well. And this you can think of as my gender is always changing, or my gender can always change, which I think is also a really cool thing. That like your gender doesn't have to be static or finite forever. It can be something that you're exploring or kind of figuring out day by day. So back to my little science corner where we talked about chromosomes. In the LGBT acronym, there is the letter I. And often people wonder, what does the I stand for? So LGBTQIA+, can think of that as standing for lesbian, gay, bisexual, transgender, queer, or sometimes questioning. I've heard people put that in there. I is intersex. A is asexual. And the plus is for any and all that have not been added into this acronym just yet. So what is intersex? Intersex is another umbrella term. I'm sure you're sensing a theme today that describes differences in sex traits or reproductive anatomy compared to the two usual ways that bodies develop. So I'm being pretty deliberate with borrowing this definition from the literature, because intersex is not something that we would use to describe someone in a derogatory way either. That sure, when doctors are looking at how your body is working, how your body is developing, there are things that they expect to see. Now, when something is not quite what they would expect, that doesn't make it wrong or bad. And so I'm being deliberate in how I talk about this, because intersex people have also always existed. There's so much more that we could say about this population and how they are treated in the medical community, how they're treated in our society, even legally. But for our purposes today, the main thing that we need to focus on is that someone who is intersex can have a lot of diversity in their primary and secondary sex characteristics, meaning how their body has developed, how their body appears. Could also be a difference in their chromosomes. These are a few examples of how someone who is intersex, their chromosomes might look on a genotype. Could be XXY, could be XYY, could be XO. If you're interested in the biology behind that, ask me about it a little bit later. But the point is that there are a lot of ways to be a person, that someone who is intersex might identify as transgender or non-binary, or they might just call themselves intersex, and that is okay too. This is just another way of talking about humans. So a big part of what we're talking about today, oops, what's going on with my slides? So sorry. We're skipping ahead and I didn't mean to. Darn Google Drive. Okay, so a big part of what we're talking about today has to do with the experience of gender dysphoria, which is something that some people experience in the trans and non-binary community, and some people do not. In general, gender dysphoria is a clinical term. We use it as mental health or medical professionals to talk about someone's experience of their gender being different, their gender identity being different than how their sex assigned at birth is identified. I really love this definition of gender dysphoria from the therapist Lucy Fielding. She's a really fantastic therapist and educator who I got the pleasure of seeing talk about gender dysphoria and sex therapy at the University of Michigan. She talks about gender dysphoria as this experience of trying things on that don't quite fit. And she talks about being young and being a child and being told this is what you have to wear for picture day. And trying on these clothes and feeling like, well, yes, they're the right size, but I don't like how they feel. I want to wear something different. And so I think of gender dysphoria as having these experiences of things not quite fitting over and over and over again. Gender dysphoria used to be a requirement for the justification of some medical transition services per WPATH, which is the World Professional Association of Transgender Health. They released, I believe, the 8th set of guidelines for best practices with this population in 2022. It is still a requirement for certain medical transition services, not all of them. Some clinics that offer medical transition operate on an informed consent model now, which is a little bit different. It's where somebody who is able to provide informed consent, so a legal adult of sound mind, body, and good judgment and insight, is able to opt into medical treatment of their own accord. But WPATH still has gender dysphoria as a requirement for things like surgery and for non-informed consent clinics for some hormones as well. And that's where the mental health and medical professions come in as functioning kind of as gatekeepers in that way. We'll touch a little bit more on that later. The important thing to keep in mind with gender dysphoria is that some people might have this experience of things not quite fitting when they are very young. If you think about it, we start to impose gender expectations on people in our society almost immediately. I mean, you can go to Target and find onesies with gendered terms on them, like Daddy's Little Angel, or for boys, Heartbreaker, or Big Flirt, in size newborn or preemie. So some people might have this experience of, this doesn't quite fit how I feel about myself when they're very young. Others might not start to feel that experience until puberty, which is another time where gender roles start to become a lot more explicit of, this is how boys grow into men, this is how girls grow into women. Some people might not have gender dysphoria even until adulthood. And some people might not experience it at all. Some people might not feel that distress or discomfort of things not fitting and still feel like my gender is different than I thought it was before, or than how other people thought it should be before. This doesn't invalidate their experience at all. There's no requirement that you have to have gender dysphoria before you can pass go and collect $200. It's simply one experience that some people have. So some people might choose to transition, which is another term that you'll hear a lot when we talk about this population. Transitioning can encompass a lot of areas of life. I was just talking about this with someone this morning, actually. So the things that we think of first are typically things like changing your name, changing your pronouns, changing honorifics like Ms., Mr., Mrs. Other things might include medically transitioning, which might mean taking medication to change your body, to change how you feel in your body or how it functions, to change its appearance. Might also include surgery in some cases. You might hear people talking about getting top surgery or bottom surgery to talk about the type of medical or surgical transition they are undergoing. There's also social transition, which is the process of, part of it is the process of coming out to your friends, to your family, at work, to people that you meet, and telling them, this is how I would like you to talk about me and talk to me. This is a piece of information I want to share with you. There's also legal transition, which is not often talked about, but is also kind of a hassle and a half from my knowledge of changing your driver's license, your passport, both your name and in some cases your gender marker on those things. Other parts of legal transition might include like calling your bank, calling your mortgage company, calling all of the places where your name, your legal name is required, and updating them about this change of information about you. So all of these different parts of transition might be how somebody chooses to respond to their experience of my gender is different than I thought it was. They might choose to transition in some of these ways, in all of these ways, in none of these ways. The overall impact, though, what we know is that when we use gender affirming language for people, when we use their right names, when we use their right pronouns, when we use their right honorifics, when we talk about them in a way that is affirming of their gender, we know that their mental health gets better. We know that someone who was feeling depressed before sees a reduction in those symptoms over time because they're not having these experiences of things not fitting as frequently, or sometimes if they're really lucky at all at a point. And this reduces their risk of depression, of other negative mental health outcomes, including suicide. We also know that accessing care providers, mental health providers, healthcare providers who are gender affirming in their treatment of patients is associated with positive mental and physical health outcomes. We'll get a little bit more into the specifics on that later as well. So what even are pronouns? You've heard me talk about them a lot. Some people are probably like scratching their heads and going back to grammar school. I get it. Pronouns are the words that refer to the person who is talking or being talked about. So for example, she's coming to the party tonight. She is the pronoun. Someone forgot their umbrella in the waiting room. They is the pronoun. Sometimes people can get a little tripped up because we're used to they, them, theirs being used as a plural pronoun. So someone forgot their umbrellas in the waiting room might be how we refer to having two random umbrellas in the waiting room. But in the last however long, I don't know the exact number of years, Their, they, them, theirs has been used as a singular pronoun as well. This is something that changed with time. This is something that I think is really beautiful about the English language. It's always changing. And so the rules that we learned in grammar school might have been updated. This might be something that is different now. So these are kind of basics on what pronouns are. Common pronouns that you've heard me use that you will probably hear in your life are she, her, he, him, or they, them. There are also what are called neopronouns, which are also kind of a cool thing from a historical perspective. These are neopronouns like z, zir, zirs, or others. Neopronouns are kind of exactly what they sound like. Neo meaning new or newly created, and pronoun meaning the word that refers to who is speaking or being spoken about. And I think this is on here. Well, it's not, but a cool thing about neopronouns is that they have also always existed. So I am a little bit of a history nerd in my life outside of therapy. I have a bachelor's in history before this. I thought I was going to be a social studies teacher. I was not for very long, but my background was a lot in American history and American history of sexuality. And the cool thing about neopronouns is that if we look back at historical writing, even as far back as like pre-colonial times, even in Europe in like the Middle Ages, the way that we refer to who is speaking or who is being spoken about has been pretty flexible historically. That there are neopronouns that were used back then that have kind of fallen out of fashion now, but that over time, our language has always evolved to describe people as they want to be described. So how do you ask about someone's pronouns? You can kind of borrow from me the way that I did at the start of this talk. You can ask people if you are in an online setting like this, if they're comfortable to share it. That way you know how to refer to them. I can see, oh, I don't know, my best friend's name is Susan. So I might say, Susan raised her hand. Susan, I would love to hear what you have to say. If somebody doesn't share their pronouns at first, you can also ask them. They may or may not be comfortable sharing, but it's not inappropriate to ask. It's actually, I would argue, quite respectful to say, like, I care about how you want me to treat you. So you can ask by saying, what pronouns should I use for you? You can say, hi, I'm Maddie. I use she, her pronouns. What pronouns should I use for you? If you make a mistake, my best advice would be correct yourself, apologize, and keep going. This is something that I often talk about in work with families or work with couples where someone is newly transitioning, is that pronoun mistakes might happen. That you've been used to talking about someone one way for however long, and then you take in new information. That's part of the learning process. Correcting yourself, apologizing, and continuing on, it allows you to both continue that process of learning, as one of my mentors would say, like getting your reps in of practicing a new skill. And also, it allows you to stay centered on that person's experience. So it allows you to not center how embarrassed you might feel by making this mistake, but instead staying focused on the conversation at hand, not making them start to feel responsible for how you feel. I see some chat activity and I'm gonna just check in for a sec. Oh, there's a cool conversation happening that I should read later. Okay, cool. I love that you guys are so talkative. This is so great. So why does all of this matter? Like, why are we talking about this today? So 0.6% of Americans over 13 years of age identify as transgender, according to research from the Williams Institute. That might seem like a small number. That is actually quite a lot. I believe that when I was putting these slides together, one of my colleagues was saying that that is like roughly equivalent to the number of redheads. I don't know if that's actually based in fact, just made me kind of laugh because she is a redhead. But that's a lot of people. So when we learn about this topic, we're learning about a good subsection of the American population. And 0.6% doesn't sound like very much, but 1.3 million does sound like a lot. 1.3 million people in the United States over the age of 13 identify as transgender. So if we look at this report from the Williams Institute, we break down prevalence data. How often does this occur? How often do people self-identify this way? We can see that about 38.5% of this 1.3 million people identify as transgender women. About 35.9% identify as trans men, and about 25.6% identify as gender nonconforming and transgender. So fairly statistically similar. It's about a third each, slightly more trans women than trans men or gender nonconforming people. If we break down how else these folks identify, we can see that there is some racial diversity as well, that it's not only a phenomenon that occurs among white Americans, despite what we might see in media. I was just having a conversation with somebody earlier today about it seems like the only LGBT people who make it on TV are thin and white and attractive. We were joking about that, but that doesn't reflect the actuality of our experience. So we look at the percentage of adults who identify as transgender versus the percentage of the US adult population. About 54% of trans adults are white, about 13% are Black, about 5.8% identify as Asian, and the other most significant percentage here is that 21.7% identify as Latinx. So if you can see, comparing these two graphs, this is about on par between the number of people in the trans population who identify with different racial categories as that percentage in the overall US population of adults. So this is a pretty common phenomenon, people identifying as trans. This is not a new thing. This is not a rare thing either, which can be kind of surprising to find out. Now into my jam, the mental health stuff. So the prevalence of mental health diagnosis in adults. 22% or 22.8% of all adults in the US experienced one or more mental illness diagnoses in 2021, according to data from NAMI. In Ohio, 33.1% of Ohio adults reported symptoms of anxiety or a depressive disorder as of February of last year. So we know that in Ohio, that might be a little bit higher than the rest of the US population. When it comes to youth, so folks aged 12 to 17, about 1 in 6 experienced a major depressive episode in 2020. And in Ohio, about 1 in 8 children received a diagnosis of anxiety, depression, or both. I'd love to see some reactions in the chat if this surprises you at all. If it doesn't, I'm going to keep going, but just for the sake of furthering the conversation, let me know how this is sitting with you. So this is the general population. So all people in the US and all people in Ohio. Among trans and gender nonconforming people, there is a higher prevalence of mental health diagnosis or mental health concerns. So I compared kind of two big studies that came out in the last few years. In a study of 52 million trans and gender nonconforming adults over 18, 58% had at least one DSM-5 diagnosis. This is compared to about 13.6% of transgender or cisgender patients. Sorry, I misspoke. So the average age here is between 35 and 39 years. And it did not include it, or it's invisible, but the most prevalent diagnoses were major depressive disorder, generalized anxiety disorder, and post-traumatic stress disorder. So that's pretty significant. 58% of adults surveyed, compared to 13.6% of cisgender adults. The way that this study was done, the method was looking at electronic health records with permission of the patients to look at trends in mental health diagnosis and treatment over about 2 or 3 years. In a similar study of about 1,300 trans and gender nonconforming youth between the ages of 3 and 17, there were some different trends identified in mental health diagnosis as well. So they found, interestingly, that attention deficit disorder diagnosis is between 3 and 7 times higher among trans and gender nonconforming youth than cis youth. And the rate of depression diagnosis is also 4 to 7 times higher. Interestingly, after I put together these slides and was all done and was ready for this presentation, a really interesting episode of a podcast came out where they talked about kind of the absence of research on trans and gender nonconforming youth, and like what do we know? What do we need to know? How do we get more information? If you're a fan at all of the podcast maintenance phase, they really get into the methodology of these studies, and they talk about how when you look at the data coming out of gender affirming care clinics for youth, sometimes their sample size is 3 patients. And then when they report the next year, we had an increase in treatment of 200%. That means that they went from 3 patients to 9 patients, 200% more than the previous year, meaning 6 more. So we're thinking about, what are the reasons why we don't have a lot of data on this population? Might be that it's hard to get care. It might be that care is not accessible for reasons like transportation or insurance or family acceptance. It might be that patients are receiving care, but because youth are not able to provide their own informed consent, that their parents are not providing assent on their behalf. So you'll notice a little bit more in this presentation too, that the data about youth, the sample sizes are much smaller. They're still significant given the rate or the prevalence of self-identification as trans and gender nonconforming, but there is so much more that we need and want to learn. So this also begs the question of why? Why are these prevalence rates so much higher among trans and gender nonconforming people? I know I am curious too. One possible explanation comes from a researcher known as Ilhan Meyer. This framework came out in 2003 and has been kind of adapted and molded in the sociology and sexuality research in the last 20 years or so. Essentially, Meyer's minority stress model says that there is a significant impact of stigma, prejudice, and discrimination against LGBT people. So in 2003, Meyer's research really only focused on sexuality and the impact of sexuality-specific minority stress. And so from there, how do these kind of system-level forces impact the environment that the person is in? And how does the environment impact their individual mental health? So Meyer's minority stress model looks at factors including discrimination, oppression, aggression from other people, internalized what he called homonegativity or homophobia, negative self-beliefs, and someone's ability to cope with stress, or what we would think of now as their resilience. In more recent years, the minority stress model has been adapted to look at what are the psychosocial stressors and barriers that are unique to trans and non-binary people because they are somewhat similar, but they are also different. And these might include things like difficulty getting healthcare services, not being able to be physically safe, having a lack of mental health support, stigma from their own community, whether that's their neighborhood, their local community, their faith community, even the LGBT community, and internalized transphobia. So in the United States, this matters for a couple of reasons. For one, there are currently 515 anti-LGBTQ bills being tracked by the ACLU in our country. I'm sure that number is different now. I am hopeful, but also skeptical that it is not higher. So we are currently living through one of the most significantly anti-LGBTQ climates of American history, at least on the legislative side of things. In Ohio, we're currently facing 7 major bills that target LGBTQ people. So if we think back to the minority stress model, this is a pretty significant way that our state and our country is expressing aggression or discrimination or oppression towards this population. And they're doing it in some pretty significant ways. So if you've heard of any of these bills, again, I would love for you to throw your knowledge in the chat. Let me know what you're aware of or any advocacy opportunities that we may not be aware of. If you are, we'll talk a little bit about that at the end too. But specifically anti-trans bills in Ohio, as of the time of this presentation, are as follows. There is SB 83, which restricts diversity, equity, and inclusion education, specifically targeting the topics of race and gender in higher ed. So this means that if this bill passes, talking about these topics will be heavily restricted or even punished, and in some cases, not allowed in higher education. So we're talking about adult students. There is also HB 245, which is a drag ban. This bill would penalize performers and venues that they are at for simply having an audience member who is under the age of 18, with harsher penalties if an audience member is under 13. There is HB 151, which does the same thing of restricting DEI education in higher ed. There's HB 6, which targets trans girls in K-12 schools by banning their participation in team sports, citing an unfair advantage is their argument. There is HB 68, which places age restrictions on gender-affirming healthcare for trans and gender nonconforming youth, and imposes pretty significant standards on care providers. We will talk in specific about HB 68 in a minute. There is HB 183, which is a bathroom ban, saying that trans and gender nonconforming youth in K-12 schooling should not use single-sex bathrooms, or they should not use the bathrooms that align with their gender identity, which we know places undue stress and burden on a biological function. Again, how many of us are able to just simply go to the bathroom and not think about it during the day? Which bathroom should I be using? We don't have to worry about that. We know we'll be safe. And lastly, there's HB 8, which is a bill that would mandate outing of trans or queer or gender non-binary students in K-12 schools by teachers and other professionals, and also place similar restrictions on talking about sexuality or gender identity. You might hear these referred to in the media as don't say gay or don't say trans bills. So as you can see, these bills that are being proposed, that are currently being argued, and in some cases will pass into law or have passed into law in Ohio, are making the environment for specifically, in many cases, youth, but trans and gender nonconforming people in general pretty hostile. They can't go to school, they can't play sports, they can't use the restroom, they can't go to a college class without having to think about how their gender identity is not accepted or that they will be treated badly because of it. And in many cases, this creates a safety issue. So like I said before, most of these bills are targeting trans and non-binary K-12 students. Some of them do extend into higher ed, which is also kind of wild. My impression is that the purpose of higher ed is to encourage critical thinking, to create the next generation of forward-thinking, free-thinking youth. This is something that I talk about a lot with my clients, with my friends. But in Ohio, it seems like there's a real focus on education as a site of controlling what people think and how they learn what they learn. So all of this means that we are facing a potential mental health crisis among trans and non-binary youth in Ohio. I would say we're not just facing it, it's here. I can tell you from my caseload that having to think about things like, where can I safely go to the bathroom? Or will I be able to play soccer with my friends next year? Or will I be forced off of the team? Leads to social exclusion, leads to safety concerns, leads to isolation. All of these things amplify the microphone of depression. So I said we talk a little bit about HB 68, which has passed, unfortunately. And this guidance comes from both the Ohio Higher Education website, as well as guidance for mental health professionals from the National Association of Social Workers Ohio, who did like a really fantastic training on what does this mean for mental health providers. If you're interested, I have a link for that later. But HB 68, in short, prohibits physicians from prescribing HRT or puberty blockers for minors and aiding and abetting these practices, meaning like helping to create access. Physicians can continue to prescribe these meds to pre-existing patients under specific circumstances. So there has to be a medical ethicist on the treatment team. The patient has to have been in mental health therapy for a certain amount of time. I believe it's 6 months or longer. These restrictions are for patients under the age of 21, which is also higher than the legal age of adulthood in Ohio. It also prohibits mental health professionals from diagnosing or treating gender-related conditions without screening for other comorbidities, meaning other co-occurring mental health or substance use issues. It imposes penalties for healthcare providers who do any of these things. And it also prohibits Medicaid coverage of gender transition services for minors, which might seem like not a big deal, but for those of us in the field, we know what Medicaid does, other insurance companies tend to follow. So if Ohio Medicaid can't cover these services anymore, not only is this going to affect all of our Medicaid clients, it's also going to affect whichever company is the next to turn over the same leaf. We've seen it happen before. We've all lived through BH redesign. So what's the impact of this? For one, trans and gender non-conforming youth will not be able to reliably access care. That's the biggest and most significant consequence. Number two, it significantly impacts skilled healthcare professionals' ability to practice. This is imposing standards from the state government on a physician or mental health professional's clinical judgment. It also just kind of gums up the works. Most gender-affirming care providers and their facilities already involve ancillary services like medical ethics and psychiatry or behavioral health when it is indicated. Not every client is going to need the exact same treatment. mental health professionals are always screening in their initial assessments and throughout treatment for comorbidities, for trauma, for abuse, at least the ones that I have known and worked with. I'm sure that all of you are kind of nodding your heads as well. This bill significantly compromises our ability to use our clinical judgment. Without Medicaid coverage, this also imposes increased psychosocial stress. It might cause financial inaccessibility of transition care. Surgery out of pocket is not cheap. It is quite expensive. Even prescription medication out of pocket can really add up. And like I said before, where Medicaid goes, other insurance companies tend to follow. This poses the risk of a trend of non-coverage, meaning that gender-affirming care for minors and potentially for adults might be solely out of pocket if this bill continues to progress and gain steam. So overall, the thing that I want to drive home is gender-affirming care is already highly restricted. Like, we don't need to be imposing additional restrictions, at least not from my perspective or from other folks in the field. According to the WPATH standards of care, the most recent best practices, there is already a process in place for determining requirements for gender affirming care. There is no specific age requirement or limit for treatment. This is left up to clinical judgment. This was actually kind of a spicy topic when the new standards of care were coming out a couple years ago, of moving from an age limit of you are an adolescent from 13 to 17 to a more developmental model of, is this patient meeting these developmental milestones at this time? That was controversial. And it ended up passing into best practices because the healthcare professionals on this committee decided, hey, adulthood and adolescence do not happen at the same time for everyone. Development is not linear. We cannot say every 11-year-old on the planet will have met this milestone by now. That's not what we see in practice, and that doesn't make sense as a standard. The WPATH standards of care already require comprehensive diagnostic assessment for trans and gender nonconforming youth before treatment may begin. That's also just good practice. I always say to my clients when they're starting treatment with me, we got to know what's going on so that we can make a plan together before we can start and jump right in. I know that you want to leave after your first appointment and feel like you've already started making progress. And I promise that we are going to start on your treatment plan almost immediately. But first, we need to have a really good picture of what will be included. And lastly, assessment under the WPATH standards of care typically involves multiple professions. There's always a medical doctor. There is usually a mental health professional, and other ancillary services may be added as needed. That might look like the involvement of a medical ethicist. That might look like adding in a child life specialist if you're in the hospital setting. That might look like speech language pathology. That might look like a lot of things. Again, that comprehensive diagnostic assessment will help us get a picture of what do we need here. So what does the research say about restricting gender affirming care? The answer is a lot. In a study of almost 1,000 adults across 74 countries in the world, about 55% of these adults reported that their access to gender affirming care was disrupted by the COVID-19 pandemic. So a little bit different. This was a worldwide pandemic. This was not a legislative event, but the result is still pretty similar. During the time where their care was disrupted, 50% screened positive for depression, 45% screened positive for anxiety. 1 in 6 participants in this study expected, I will lose my health insurance. So we know that disrupting access to care has negative mental health outcomes. In a similar study of about 100 youth, ages 13 to 20, 60% who were able to access gender affirming care had lower odds of depression and 73% lower odds of suicidality over 12 months follow-up. So what we know from these two studies is disrupting care leads to worsened mental health metrics. Access to care tends to improve mental health. So what do we do about all of this? I don't want to leave you on a note where you're feeling very stuck or hopeless. I also want to be mindful of time in case there are questions as well. But I do want to make sure that we have a minute to talk about what we can do. So for parents and families, or generally just loved ones, you could be a friend, you could be a neighbor, there are a lot of resources in Northeast Ohio specifically for loved ones of trans and gender nonconforming people. For one, Honesty for Ohio Education, honestly, where I sourced a lot of my legislative information today, has fantastic information about what are the bills that are currently pending, what would they do, what can we do to advocate for them not to pass into law. So I would recommend going there if you have some time after you click away from the screen today. If you or a loved one have someone who is in need of gender affirming healthcare, we are super lucky in Cleveland to have two pretty major adult and pediatric pride clinics, meaning clinics that work with LGBT patients specifically. And I have some colleagues at both of them who I love and respect. So Cleveland Clinic and Metro Health, and I believe now UH also have a pride clinic. UH, I think you might need to be referred to it through your primary care physician. If somebody else in the audience knows differently, please let us know in the chat. I love to be corrected. And in terms of advocacy resources as well. In Cleveland, we are lucky to have the Colors Plus Youth Center, which offers therapy and support groups and other really great services for LGBT youth, I believe up to age 18, but they have some young adult programs as well. For parents and families in specific, we have Listen and PFLAG. And I always love to plug them because I was lucky enough to volunteer with them last year. We also have in Ohio Camp Lilac, which is one of the first ever summer camps for transgender and gender nonconforming youth. I volunteered there as a mental health counselor last year. I'm not going this year for obvious reasons, but I'm hopeful that once this kiddo is old enough, I can bring them with me. But they do really great work around giving trans and gender nonconforming youth a place where they can just be kids and not have to worry about that extra stress. They can just go to camp with people who have the same experiences as them. They're so wonderful. For clinicians, I have a link to that guidance on the impact of HB 68 if you are at all interested. It's really comprehensive. I suggest downloading it and referring back to it. I definitely have it on my desktop. And if after this training, you're thinking, I would like to learn more, I would like to become more LGBTQ affirming in my social work practice and my mental health practice, I can plug two different places where you can do that. There are obviously a lot more. These are just two that I recommend. The Affirmative Couch is one that's really great. They're all online based. They're out of California. You might notice that I've done some writing from them in the past, but I promise I don't get a kickback, or I would have told you at the beginning about a conflict of interest. I just really can vouch for and respect them as continuing education providers. They have CEUs for social workers, counselors, and CMEs as well, I think. They might have MFT CEUs as well, I could be wrong. And also the University of Michigan Department of Continuing Education. They have a lot of really fantastic webinars as well. They're fairly affordable. If you're a student, may I suggest that you reach out and ask for the student rate. Sometimes they will let you take them for free. And because Michigan is so close to Ohio, I've known people to have pretty good success getting them approved by the Ohio Continuing Education Board. So that's good. For everyone, if you are feeling like I just want to support some great organizations working with this population. Can't go wrong with any of the above. The LGBT Center of Greater Cleveland does great work. They have resources for just about any psychosocial stressor you can think of. They have care navigators, they do support groups, they do a whole lot of other fun stuff too. Margie's Hope is a resource center that has clothing for people who are transitioning. They have a pretty good size range, I've found. Like if I have clients that are like, ooh, I need men's pants with a short inseam, they've got them there, which is awesome. There is Trans Ohio, which does advocacy and education work for the trans and gender non-binary community. And there's also the Trevor Project and ACLU Ohio, which do similar education and advocacy in our state. So that's it for my presentation. I told you I wasn't going to try and talk the whole time. Thank you guys for being such an attentive and responsive audience. Do we have questions or things?
Yeah, thank you so much. How is my audio sounding now? Is it okay?
Great.
All right, great. Yeah, just, really appreciate the dialogue that's been occurring in the chat throughout the presentation, seeing a lot of good sharing of resources and information and shared experience, for some of the folks in the chat who have children who are trans or non-binary or gender non-conforming. So thank you to everyone who's been involved in participating in the chat with us. I was wondering, I had one question. You had alluded earlier to sort of like the intersecting prevalence of ADD or ADHD and trans and non-binary identity. Is there any I'm noticing someone else pointed this out in the chat too about like Gen Z and Gen Alpha expressing what they identify as earlier than maybe previous generations have, partly due to that openness, accessibility, acceptance you're talking about. And I'm wondering also about autism and trans and non-binary identity. Is there any I know there's limitations on the research, but it seems like there's a shared prevalence of and like neurodivergence or neurodiversity and gender diversity. Can you speak on that at all?
Yeah, absolutely. It is definitely a growing body of research. You are right. And it's been really interesting to see like more and more knowledge come out of the intersection of trans and gender nonconforming people, youth in specific, and neurodivergence. Most of what I know comes from a clinician, Dr. Kristen Neff, or not Kristen Neff, just Dr. Neff. I'm mixing them up with a different Dr. Neff. Ooh. But their website is called Neurodivergent Insights, and they do a really good job of kind of compiling the research on the intersections of different populations within mental health. And a lot of what they have found is that like when someone's brain works differently than how we would expect a brain to work or a brain to develop, it is also not uncommon for them to think of themselves or identify themselves differently. And the more that we learn about that, the more we can treat them effectively as clinicians, the more that we can make space for these conversations. And because this is a growing body of research, like, yes, that does mean that we're seeing a higher prevalence. Thank you for the person who put it in the chat. We're seeing a higher prevalence among younger clients, and just anecdotally too, we're seeing a higher prevalence of diagnosis by younger therapists too, or younger professionals. I always kind of joke with one of my colleagues that you can kind of tell like when somebody came up in the field. That's not always true. That's a gross overgeneralization, but certainly I would say that a lot more of my like go-to ADHD referrals or go-to autism referrals are therapists in their 20s, 30s, and 40s, just because they might have had more access and more exposure to this information in their training. So I'm really excited to see more about this intersection in the literature as time goes on.
Thank you for that. Did want to bring to everyone's attention, I did put the link to the survey, the brief anonymous evaluation for this presentation in the chat. We appreciate your honest feedback. If you could complete that for us before we wrap up. Not seeing any more questions in the chat, just some expressions of gratitude for this presentation, very informative. Again, this is being recorded, so you can view it at a later date on our YouTube channel, and I will be sending a follow-up email with the slides. Definitely want everyone to have some of those links to those resources that were provided in the last few slides. So any final questions before we conclude this webinar? Now is your time. Just give it a minute or so. All right. Not seeing anything, so I think we will wrap up here. Thank you all for being here and hope everyone enjoys this sunny day. A great day.
Thank you, folks. It's nice to have you.